Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. I'm Zach Caseberg, your tutor, coach, and guide along the path of passing the RD exam. I'm so excited you're here because if you are, it means that you want to learn more about passing the RD exam, and trust me, you're in the right place. So many of you may be already practicing RDs or RDs to be in all different types of settings. And many of us could just be studying during this phase, really just working on passing the exam itself, which is totally okay. Each way kind of has the benefits of another. If you're studying, you can really focus on that. And if you're practicing, you also get that experience of really doing a lot more things in practice. And sometimes for challenging topics, this can be really helpful. Especially if you're working in like the clinical setting, you're getting so much more exposure to different diseases, pathologies, what their treatment is. So that's just one benefit of something like that. Heart failure, in particular, is one that if you're working in a hospital, there's a good chance that you're going to see it. So that's going to be our topic that we talk about in this episode is heart failure. Another note I'll say is that sometimes you might hear me say congestive heart failure or CHF, and we're considering this the same thing as heart failure in this case. We're going to break down the pathology, the medical management, the nutrition therapy, and go through a couple practice questions that you can use for your exam day. We'll start with that pathology and its definition. So, heart failure defined is an impairment of the ventricles, and this impairment leads to those ventricles of the heart having difficulty pumping adequate blood to the rest of the body. And it often occurs in conjunction with other cardiovascular diseases like atherosclerosis, one of the harder ones to say, myocardial infarction, strokes, other issues of the heart like hypertension can all lead to CHF eventually. Since we see higher incidence of hypertension, other cardiovascular disease leading to CHF, we can see that the populations that are mostly affected with a condition like this would be like Black Americans, who will have much higher rates of hypertension and cardiovascular disease, followed by Hispanic, Caucasian, and Chinese Americans. Why heart failure is so important to us as kind of clinicians is the fact that it's a major concern for hospitals and hospitalizations. It's very costly to insurance, and there's a really high amount of readmission that occurs with heart failure, meaning people come back with it to the hospital over and over. This is very costly to hospitals, so that's why they employ people like dietitians to help out with making sure people change their habits and don't end up back in the hospital. We're going to start with our patient, and we're going to start with what I want you to imagine an injured heart. Now, this injured heart has been subjected to hypertension, myocardial infarction, some type of injury or damage. Now, the heart, because it's a little weak, it now requires a little bit extra help to maintain that cardiac output, to push blood to the rest of the body. Now, we can maintain this for just a little bit, right? What happens is the heart compensates. That ventricle that might not be doing so well, it actually grows and stronger. Actually ends up hypertrophy. Hypertrophy is when we build up those muscles, make them bigger, right? This is great if you're working out. But in the heart, hypertrophy isn't always such a great thing because the heart is a muscle. That ventricle grows wider and hypertrophies, and now we're having this much smaller area of pumping blood, right? So the heart has remodeled and compensated to grow, and now it's in an even worse position. What we start to see is hormones like norepinephrine, which normally help with that heart contractibility, but they also help with activating the RAS system. The RAS system being that renin, angiotensin, aldosterone system, right, that we talk about. And it's very essential for maintaining blood pressure, this RAS system. But when that RAS system gets activated, we get this high amount of aldosterone and an antidiuretic hormone that are activated. And they both end up conserving fluid and conserving sodium. Aldosterone also promotes that sodium resorption. So now we have this enlarged ventricle, And then we have all this sodium and fluid retention because the blood is not adequately able to be pumped to the rest of the body. This is a big problem. That enlarged ventricle, one other thing that you're going to see is those ventricles can release a substance called BNP. BNP is going to be something that's really commonly used to see if a patient is going through heart failure. Now, this patient is in trouble, okay? They're having difficulty pumping blood to their organs, their brain, digestive tract, kidneys, and muscles. That RAS system is activated because we're not getting enough blood flow to the kidneys. So now our blood pressure is going up even higher. And that blood pressure can go up so high, that fluid retention can be so high that it can lead to pulmonary edema, pulmonary congestion, death, all kinds of issues. This patient is going to be showing some particular symptoms, such as dyspnea. Break that word down. Difficulty of, pnea, breathing. So difficulty breathing, fatigue, weakness, and shortness of breath with exercises that normally wouldn't make them short of breath. They'll also eventually end up with things like hepatomegaly, splenomegaly, these growth of these organs due to this pressure. And they'll have ascites and fluid retention in their abdominal cavity and probably in their legs and other areas too. All of these conditions all come together to affect things like their nutrition status and even lead to things like cardiac cachexia. Cachexia being a wasting disease that's linked to these inflammatory cytokines that are released in the body. So all you're seeing here is this start of a condition is really leading down something really terrible, really fast that's affecting their whole body and their nutrition system. Make sense? Make note of some of the medical treatments that could be used for heart failure. A medication list for this patient could include diuretics, which would help to, of course, remove that sodium, remove that fluid, and reduce that blood pressure a bit. Vasodilators to help open up those blood vessels and relax them, reduce that blood pressure. Inotropic agents that can help control heart contractions. Anticoagulants could be in there to prevent coagulation. Beta blockers and other types of medications could also be used just to help control, relax, and help control that heart a little bit. A large piece of the treatment of heart failure, though, is what we do RDs to be. It's going to be that nutrition therapy that can be really essential to help prevent that patient from being readmitted. So now we're going to learn about that nutrition therapy, that MNT, and how we're going to apply it for the exam day. Firstly, heart failure and MNT is going to focus on a few things. Primarily, we're going to start with sodium and fluid intake. Now, why is that RD to be? Why do you think that we're focusing on sodium and fluid intake in this case? We know much of what led us here was the hypertension, the fluid retention, and we know when a patient has developed heart failure that now they're having even more issues with edema, fluid retention. So we need to go ahead and act on those things. Our goal should be to restrict sodium in fluid to control blood pressure. An initial sodium restriction may look something like 2,000 milligrams or less per day. I've seen doctors put a patient on 1,500, 1,200 milligrams sodium, so there's not an exact advisement. It'll kind of be specific to the patient, but basically restricting to less than 2,000 per day. Your nutrition therapy should also tell the patient to focus on kind of controlling their sodium intake through the types of foods and habits they eat. We'll talk about this in a minute. And another important piece is going to be that fluid intake. Fluid restriction for this patient is typically the hardest part, and it might be around 1 to even 2 liters per day is what's been seen. A patient's sodium intake their serum sodium, their blood sodium level, will usually be monitored to see how much they need to restrict their fluid. By providing less fluid, we're keeping their blood pressure down and preventing this heart failure from occurring. Your nutrition education might revolve around making sure the patient understands what is fluid. Ice being fluid, gelatin, sherbet, milk, custard, all these things would fall into their fluid allowance in a day, and they need to use that to calculate it. As important as the sodium in fluid restriction is, it's not the only piece that I need you to focus on when it comes to CHF. Keep in mind, with this cardiac cachexia, this patient is at a really high risk of anorexia, malnutrition, weight loss, due to all the things they're going through. Meeting their caloric, protein, their nutrient needs in general is so essential for their kind of longevity and, preventing their length of stay. Common nutrition deficiencies that are going to be seen with this patient would be things like thiamine, magnesium, and other water soluble vitamins. One reason that could be we're not absorbing them too well, but I'll bet you that they're going to be on diuretics, and diuretics are going to affect all of these types of minerals in different kind of water soluble vitamins, right? For caloric needs, these patients should focus on a moderate increase in their caloric needs, and this is mostly to prevent that cardiac cachexia from occurring. If possible, you should try to calculate their caloric needs through indirect calorimetry, and if you didn't have that, which is most cases, we would want to use an appropriate predictive equation of some kind. Keep in mind that these patients are going to have a lot of edema. When you're calculating needs, you may consider calculating based on their typical dry weight if they have 10 pounds of extra water weight on them at that time. A high protein diet and protein intake is also something that is specifically mentioned to focus on with a patient with CHF. Because they're at such a high risk of that cachexia, losing muscle mass, we need to make sure that they maintain it as much as possible. What I've seen is 1.1 to 1.4 grams per kilogram should be used to provide a patient with adequate protein intake. I think we could summarize this all to say that the patient needs moderate increase in calories and a moderate increase in protein. To summarize, your nutrition therapy for this patient will largely be focused on education and meeting their nutrition needs. You'll provide education on low sodium and fluid restricted diet for a patient that's being discharged. Your patient will be expected to weigh themselves daily to monitor for excessive fluid retention. And you're going to provide recommendations for high protein intake in meeting their calorie needs. This would go into things such as making sure that they're doing habits at home like a cardiac diet, whole grains, fresh fruits and vegetables, low sodium or fresh meats, as well as kind of avoiding things like alcohol, tobacco, other cardiac harmful substances, and excessively salting their food is probably the biggest one I see. If your patient was still admitted, you're probably not giving education quite at that point yet if they're not being discharged. If they were still in a really terrible spot, your nutrition therapy would largely reflect meeting their nutrient needs and maintaining their appropriate dietary needs based on their medical treatment. This could lead to things like implementing snacks, oral nutrition supplements, and when necessary, providing nutrition support while being just very cognizant of fluid restriction and how dynamic that fluid can be. Now let's shift gears and let's talk about some practice questions together. If you enjoy these questions and you want to follow along, don't forget that you can watch this on the RD Exam Ready YouTube page if you just want to watch and see that visual and follow along on these as well. I'm going to give you 3 practice questions on CHF. Remember, the tips that I'm giving you is how to effectively approach a standardized question, how to solve it, and put yourself in the best position towards getting that question right. This is kind of going to be a thoughtful strategy towards approaching these, and it can serve you very well as it's served hundreds of my other students to pass the exam. Let's start by reading the question carefully. A patient is being discharged from the hospital, and the RD has been assigned to provide a discharge nutrition prescription. Which of the following would be the most appropriate prescription for a 100 kilogram male patient? We're going to read through each answer first and then go through to see what we think about them. A. Sodium restricted, fluid restricted, low protein diet. That's answer A. B. High sodium, fluid restricted, low fat diet. C, high carb, low sodium, high protein diet, or D, sodium restricted, fluid restricted, high protein diet. Now I'm going to go through each answer and let's look at that question itself really quick too. So the patient's being discharged, we need to give them a prescription, and we need to pick the best one for a 100 kilogram patient. Let's start with A. I want to ask if you think it's a good answer, a bad answer, or maybe you just don't know. What I did on my exam is I wrote each one of these down on my whiteboard and followed along with it so I could keep track. Starting with A, sodium restricted, fluid restricted, low protein diet. When I read this one, I don't think this is going to be my best answer. The thing that threw me off the most in my gut is the low protein diet part of it. While sodium restricted, fluid restricted sounds good, low protein would not apply for CHF. Answer A is going to be removed for me. For B, high sodium, fluid restricted, low fat diet. We don't recommend a high sodium diet for a patient with CHF, so I don't think B would be an appropriate answer either. C, high carb, low sodium, high protein diet. I don't remember carbohydrates being mentioned much in this. I'm going to put a little question mark by C for right now. In D, sodium restricted, fluid restricted, high protein diet. I like D because it hits all my points of what I focus on for CHF. If I was stuck between C and D, D is the one I felt best with, and D will be our best answer. Sodium restricted, fluid restricted, and high protein diet would all be good ones that could be used for a patient with CHF. Number 2. A patient with CHF is showing signs of lower extremity edema. This is likely due to A, a ventricle size decreasing, B, the patient is following the DASH diet, C, aldosterone and angiotensin causing increased fluid and sodium retention, or D, excessive exercise. Patient is showing signs of lower extremity edema. This is due to. Let's start with A. The ventricle size decreasing. I'm going to put a little question mark by that one in this case. B, the patient is following the DASH diet. I don't think this would be my best answer because I think if the patient was following the DASH diet, which is a low sodium diet, I think that actually they would not have this edema, or perhaps it wouldn't be as bad as it is. I'm going to get rid of B in this case. C, aldosterone and angiotensin causing increased fluid sodium retention. I like this as a good answer because it fits very well to why the lower extremity edema could be caused. D, excessive exercise. I would have to go with C as my best answer. I think the aldosterone and angiotensin is causing this fluid and sodium retention, and that's causing some of this edema they're having throughout the body. I would go with C as my best answer for this one. Number 3. A 75-kilogram female presents to the hospital with dyspnea and coughing. Her BNP is elevated, and she reports recent weight loss secondary to inability to consume meals due to fullness and chest tightness. She's not able to provide a 24-hour recall. What would you suggest as the appropriate nutrition problem? Let's break the question down a little more. It's long. Patient 75 kilograms. She has shortness of breath and coughing. She has a high BNP and weight loss. She says her weight loss is caused by not being able to eat big meals and just being chest tightness. She can't provide a recall, but we need to provide the good nutrition problem. A is inadequate energy intake. B is obesity. C is unintentional weight loss. And D is severe malnutrition. For A, inadequate energy intake, I want you to be careful about this answer, RD to B. It seems like a good one, but let's check our question. What I would ask you is, at any point was this patient able to tell us how much calories she eats in a day? Or was she able to provide a 24-hour recall in which we could infer that she's not getting enough calories? We don't have this information, RD to B. We just don't have it. A would be a question mark for me, or I'm going to get rid of it because I want you to read through these other answers to see if there's a better fit. B, obesity. Well, I don't know what her height is, for instance, so I can't really say what her BMI is. I don't think B would be a good fit for this, and this doesn't sound like obesity being the main nutrition problem. C. Unintentional weight loss. I like this as an answer because it's directly reported to something she has told me. She reports recent weight loss secondary to inability to consume meals due to fullness and chest tightness. I like this one. C. Severe malnutrition. She may be malnourished, but to be honest, I don't think I have enough information to say whether she is or not. I only know she's had recent weight loss and isn't eating well, but I don't know if I have all the info I need for inadequate energy intake or severe malnutrition. So I would go with what I know, which is that this patient has unintentional weight loss. Now that's a wrap today, students. I hope you listened, learned, and enjoyed joining us for today's podcast. Remember that passing this exam is a journey. We all need assistance along the way. Do yourself and me a favor, hit that subscribe button, tell your friends about the RD Exam Ready podcast if they're studying students, rate, review, or just help spread the word. And remember, as always, happy studying RD to be.